So we are ready to start. Dear participants, my name is Maria Rodriguez. I am the dissemination manager for the EuroBloodNet. And it is my great pleasure to welcome you on behalf of the EuroBloodNet to the Thursday webinar of Professor Olivier Tournilhac on Prolymphocytic Leukemia. A European online education program targeting health professionals organized by EuroBloodNet. Thursday webinars are educational activities designed to promote interest in highly innovative topics with the goal of disseminating the latest advances in rare hematological diseases to healthcare professionals. To that end, we will be attending a lecture on Prolymphocytic leukemia. And so, dear audience, we please welcome the speaker of today's session, Professor Olivier Tournilhac. Professor Tournilhac is a hematologist attending physician at the University Hospital of Clermont-Ferrand in France. He teaches hematology at the Clermont University, and he is the chairman of the T-lymphoma subcommittee of LISA, and a member of the board of directors of the Philo Group and of the board of the French Society of Hematology. His research is focused on clinical and translational research in T-cell lymphoma, T-cell prolymphocytic leukemia, chronic lymphocytic leukemia, and Wallstrom microglobulinemia. So, final house rules. Before starting, still some technical information. The session is recorded because the session will be implemented in the EuroBloodNet learning environment. So if you are not comfortable with this, please turn off your camera. Also, please be advised that your microphone is mute. If you have any questions about the presentation, please write them down in the chat. They will be answered in the question and answer session at the end of the webinar. You will find the chat at the bottom of the screen at the cloud symbol. Dear audience, please welcome with me the speaker of today's session about Professor Tournilhac. Professor, the floor is yours.
Good afternoon, everybody. Thank you, thank EuroBloodNet to invite me to give this webinar on T-cell prolymphocytic leukemia. There was some misunderstanding on the name of the topic called T-lymphoplasmacytic leukemia, which is not an existing entity, and we'll clearly talk about the T-cell lymphoproliferative disorder, which is T-PLL. Here are my conflicts of interest. So the learning objective of the webinar is to define what is T-PLL, how to diagnose a T-PLL, and to give insight in disease management, focusing on actual available tools. So the clinical presentation. T-PLL has been recognized not so long ago. It was in 1973 by Daniel Katowski, and this had been published in a Lancet, a rare form of T-cell CLL. This is a mature T-cell neoplasm arising from the adaptive immune system, and this is quite different to precursor T-cell lymphoblastic or lymphoma or T-ALL. So it's a leukemic presentation of a mature T-cell neoplasm, and this T-cell neoplasm is in the same group of other extranodal or nodal T-cell lymphoproliferation, but it's confined in the leukemic area of this mature T-cell neoplasm. This is a rare disease, 2 per million and per year, and it's only 2% of mature leukemias. So the clinical presentation, median age is around 65 to 70 years old. The typical presentation is aggressive, widely disseminated, with progressive lymphocytosis, which can reach extremely high level, spleen enlargement, adenopathy, cytopenia, and P symptoms. The alternate presentation can occur. Some patients can have primary extranodal, including involvement of pleural effusion, peripheral edema, skin lesions, CNS, more frequent at relapse, but usually these extranodal involvement will occur with the typical presentation. And there is also very indolent form, eventually evolving to a more aggressive form. The overall survival of this disease is short. It's such overall survival can be seen in other very severe cancer like pancreatic cancer. This overall survival here is a mix of patients who are frontline, relapse, and also patients with indolent initial form of the disease. So it's important to have a look at some difference on survival depending on the status of the disease. As you can see, frontline patients will obviously have a longer survival than salvage patients. Here, 14.5 months compared to 4.4 months. And untreated patients have a time to first line of 2.3 months in this series. So indolent forms can be diagnosed on, for example, on a blood count with very few symptoms. And such patients have a progression of 62% at 6 months. The median progression rate to an active form is 33 months. So these indolent forms have a longer overall survival, but once the indolent becomes aggressive, then the survival is the same than aggressive form. The clinical presentation here is resumed in the table. You have these median age around 60 to 70. So when you have patients with indolent form, 5% adenopathy, but when this form is active, it's around 50 to 60%. As is splenomegaly, rare in indolent form, much more frequent in active form. As are also skin involvement, hepatomegaly, effusion, and as are also cytopenias. So in indolent form, you have only 10% cytopenia, thrombocytopenia, but it's up to 30 to 50% in active forms. So, T-PLL can develop in the context of ataxia-telangiectasia, which is an inherited disease with ATM-B allelic mutation. And in this condition, there is cancer predisposition. Here, a retrospective French cohort of 278 ATM-80 patients with a follow-up of 15 years recorded 70 cancer with 3 T-PLL. So the incidence in 80 of T-PLL is 68 per 100,000 cases. So how we do the diagnostic? The diagnostic is firstly based on cytology of the blood, and the classical type of T-PLL cell is in cytology median size with high nucleocytoplastic ratio, condensed chromatin, one visible nucleole, and these peculiar blebs around the cells. But there is variant in cytology here, so these are clearly T-PLL, but here there is CLL-like with a nucleole non-visible or only mildly visible. And here you can see the beginning of the bleb. And there is also patients with irregular nucleus, either cerebriform or with a flower-shaped nucleus. And such T-PLL can be mistaken for Sézary or ATLL. Flow cytometry is a second major tool of diagnostic. Usually, you may need to have a rather complete panel to be sure of your diagnostic? Well, it's positive for CD3, possibly low, negative for these two markers of immaturity, CD1A and TDT. This is what these markers are positive in acute lymphoblastic leukemia of T-cell phenotype. So this is a major tool for differentiating the two conditions. Positive for various isoform of CD45, positive for CD2, 5, and 7. No aberrant loss of positivity of these three T-cell markers, with a variable expression of CD4 and CD8, with this very classic but not very frequent double positivity CD4, CD8. And there is rarely a double negativity of both CD4 and CD8. The clonality can be now done by flow cytometry using TRBC1, which can be really helpful if you have this on your panel. There is additional panel markers which can be very useful when the diagnostic is not sure, including the expression of TCR, which is mostly alpha beta. And CD52 can be important for treatment, and it's CD25 negative in 80%, CD16 and CD56 negative, which is important on differential diagnostic. TCL1 positivity is tricky in flow cytometry because you need to do permeabilization. But conversely, if you have tissue available, it's much easier by immunochemistry. TCL1 is involved in the most frequent abnormality in cytogenetics of T-PLL. So you have an abnormal karyotype in more than 90% of cases, and a complex karyotype in 70 to 80%. At the TCR locus at 14q11 can be rearranged with the TCL1A and B genes in 70% of cases, and in less than 10% with the MTCP1 gene at XQ28. These are founding event and major event, major diagnostic features of T-PLL. There is gain of MYC gene along with abnormality of chromosome 8 in 75% of cases, 70% of 11q23 deletion of ATM gene, and 20 to 30% TP17P deletion. Other abnormality are frequent, but the karyotype can be really complex in 70 to 80%. So this is an interesting case of a 70-year-old woman with isolated, slowly progressive lymphocytosis, which reached 5.5 in 2019. So the cytology were medium-sized cells, high nucleoplasmic, high NC, basophily, nucleoles. The phenotype was TDT negative, 2+, 3+, 7+, 4+, 8 NAC, pending diagnostic. And the result of the karyotype was 46XX in 20 mitosis. Well, we had some trouble to do the diagnostic of this T-cell lymphoproliferation. Then had to do the karyotype with the proper mitogen. Here is 72 hours with I2-CpG, which is used to do the karyotype in standard BCLL, which was done routinely in our lab. But when you ask with the proper mitogen on the same patient at the same day, you have these very complex karyotype with these abnormalities involving 14q11, 14q32, and abnormality of the chromosome 8. So be careful of the condition of the karyotype, which that can be tricky. So back to the diagnostic procedure. So based on clinic, cytology, cytometry, cytogenetics, 4C, you can apply the recently described criteria of the T-PLL ESG published in Blood by Philippe Staber recently. And we have 3 major criteria: more than 5 in the blood of T-PLL phenotypically typical cells, clonality, and abnormality of TCL1 or MTCP1 gene. These are the 3 major criteria. Then the diagnostic is done. But if you don't have these criteria, you can still do a diagnostic of T-PLL in the so-called TCL1 family negative T-PLL group, which is a heterogeneous group. Well, we'll probably know more in the future of this kind of patients, and to clearly study such patients, we need more tools, including targeted NGS, extended flow cytometric panel, tissue histology for TCL1, and hybridization in situ for TCR, TCL1, and TCP1. So targeted NGS will uncover the molecular features of the disease. And the molecular landscape have been extensively studied by Hill and Stengel, and then by Schrader. And there is these important frequency of ATM mutations and TP53 mutation, much less frequently, and also on this JAK-STAT pathway. So on the JAK-STAT pathway, there is 4 described kind of mutations, not frequent IL-2 or G mutations, but especially more frequent JAK1, JAK3, STAT5B mutation. STAT5B mutations are in the SH2 domain, while JAK1, JAK3 mutations, the pseudo kinase domain. And there is some almost hotspot mutation, that this one N642H mutation, and conferring particular aggressivity of the disease. So in summary, molecular landscape, for molecular landscape, you have DNA damage repair mutations in up to 100% of the case, either ATM mutation and or ATM deletion. Sorry, you can have TP53 mutation and or deletion, and both are a little bit mutually exclusive. There is 75% JAK-STAT pathway mutations, and there is also epigenetic mutations and other mutations, including CDKN1B deletion. So Schrader published a few years ago proposed clonal evolution of T-PLL. So the first step could be the alteration of TCL1 expression with increased TCL1 expression, and the second step, ATM mutation and loss. So you have a healthy cell becoming a T-PLL with the conjunction of ATM defect and TCL1 input. And then there is, you have a pre-leukemic cells, and you need more steps to become an active T-PLL. And these more steps can be miR38B loss, the gain, the AGO2 and SH2 gain especially. And the last abnormalities are the mutations occurring in the JAK-STAT pathway. So the prognostic, as we mentioned earlier, the disease is aggressive with a poor survival, and prognostic is impacted especially by disease status. So you have a patient with an indolent form of T-PLL. This patient could have more than 5 years overall survival in median. You have a patient with an aggressive form, then obviously the survival is shorter. The same is with the not the same difference, but such difference can be seen also on frontline versus salvage patients. So when you look at an overall survival on the whole group of this rare disease, then you want to put every patient together to have a big series. Then you have different kind of patients with indolent, frontline, and relapse patients. And obviously, such patients related to the disease status have different survival. There have been attempts to describe some biological marker of aggressivity, including anemia, LDH, BT2 microglobulin, JAK3 mutations, but there is no clear and useful tool to predict in one group of disease status patients, like one group of first-line treatment, who will be the patient who will do poorly compared to the other. Maybe JAK3 mutation is the most relevant. Now back to the management. So patients with indolent course should not be given early treatment, but they need to have close follow-up, because the disease can go from indolent to aggressive course rapidly from one appointment, between one appointment and the other appointment at 6 months. So it's better to see at the minimum patients every 6 months with indolent T-PLL, no less, and to have full blood count every 3 months, no less. Then patients with active disease are to be treated, and mostly the reason to treat the patients with T-PLL is the occurrence of constitutional symptom, symptomatic bone marrow failure with anemia, progressive anemia, thrombocytopenia, rapidly enlarging lymph nodes, spleen, and liver, rapidly increasing lymphocytosis, and extranodal involvement. So what are the treatment options? We have retrospective analysis showing first that in patients treated by CHOP or single agent alkylator or irrigation, the overall survival is below 12 months. In the early 90s, have been developed the pentostatin treatment, and here you can see in patients in relapse after alkylating, you have a 40 to 40% overall response rate with a PFS of 6 months. And more recently, in 2014, our French colleague Charles Herboin published a series of 15 patients treated with bendamustine every 3 weeks with a 50% overall survival, but this was both in relapsed refractory and frontline treatment. So these two options are possible options of treatment of T-PLL. But as you can see, there is many groups and many, well, there is literature on alemtuzumab. So I will concentrate here on prospective trials on alemtuzumab-based treatment. So as you know, alemtuzumab is an antibody directed against CD52, and this CD52 is constantly expressed by T-PLL. But the expression can be lost after alemtuzumab treatment, and should be rechecked before any retreatment. At diagnostic, CD52 is expressed. And alemtuzumab-based treatment in all these prospective trials, the frontline, a high overall survival. Here, you know, with these 32 patients treated by a monotherapy, you have 91% overall response rate, 81% complete response rate, and 35% overall survival, so 35% survival at 48 months and 68 and a PFS of 67% of 12 months. So in summary of alemtuzumab alone or in combination frontline, you have a high overall response rate of at least 80 to 90% and a complete response rate of 80 to 90%, but with a PFS which is a little bit above 1 year and an overall survival which remains below 4 years. Alemtuzumab is a standard to be used with caution. We used alemtuzumab a lot in CLL during the year 20 to 2010, 2015, before the arrival of BTK and BCL2 inhibitors, and also PI3 kinase inhibitors. And so we had learned a lot in the management of patients with CLL treated with alemtuzumab. And it's very important to provide patients adapted supportive care. First of all, you have to manage infusion reaction to try to improve tolerance and then drug acceptability. And you don't want to stop drug after 1 week. So you have to communicate with the patients about side effects a lot. So subcutaneous administration provide a better tolerance but loss of efficacy versus IV. That's been shown by Claire Durden. You have to use a ramp up and also to use steroids, etc., to mitigate the infusion reaction. Infusion screening and prevention is mandatory. Cotrimoxazole, valacyclovir, CMV screening, as is blood product irradiation, hematopoietic growth factor. And you have to be aware that on alemtuzumab, especially alemtuzumab plus paltusotine, you can vary kind of infectious complication, including CMV and EBV reactivation, fungal disease, etc. You can have immune reconstitution syndrome weeks after the end of alemtuzumab. You can have a negative with autoimmune disease. You can have a negative impact of T-cell engraftment after allogeneic transplantation. Then you need to observe a washout of alemtuzumab of at least 8 weeks between the end of alemtuzumab and the allogeneic transplantation. And also, and last but not least, there is a constant risk of drug shortage with this agent. So the medical community has to stick together to maintain this drug available because we need this drug to treat T-PLL patients. So long survival post alemtuzumab has been described by Claire Durden, and her conclusion is that all these survivors beyond 72 months are those who received consolidation with hematopoietic stem cell transplantation, either auto or allo. These patients were either frontline or relapse, 86 patients treated with alemtuzumab. So allogeneic transplantation have been reported retrospectively, with the exception of these study, which was a prospective data collection, and but not really a clinical trial. And as you can see here, patients, so there's a wide range of years and of years of allo. So it's difficult to compare patients transplanted 20 years ago and now. But so we have to be careful in making this comparison. Almost all patients had been pretreated with alemtuzumab. The disease status before transplantation was either CR, mostly CR, but somewhere in a stable disease or progressive disease. And usually there was a unrelated matched. Usually the donors were HLA-matched unrelated or unrelated donor. But there was some exception with the occurrence of patients who've been transplanted with mismatched donor or with cord blood or with haploidentical donor. So the overall, the TRM is 30% in all these series. There is an important rate of cumulative incidence of relapse of at least 40%, with a 30 to 40% overall survival. These are two studies of the French Society of Transplantation, and this is a series of 27 T-PLL, 63% with reduced conditioning and reduced intensity conditioning, and here you have a 40 to 50%, 50% cumulative incidence of relapse. And if you compare to 285 case of peripheral T-cell lymphoma, another major lymphoma, the cumulative incidence appear much higher in T-PLL than in PTCL. Well, you cannot be sure by doing this kind of comparison, but it sounds that there is something wrong in a T-PLL. And this is also seen in other series. There is also the problem of non-relapse mortality, which is around 30% at least in all these series. Finally, we have this prospective data collection done by the EBMT and published by Victor Gerediak. And patients were below 65 years old for almost all of them. They had mostly been transplanted in first complete remission, 22 in first PR, and very few patients in stable disease or progressive disease. And they all had, almost all had been pretreated with alemtuzumab, with a median time of alemtuzumab withdrawal of 75 days. And here you can have, there is this 32, this, the habitual picture of this disease, 38% relapse rate, 42% overall survival with a non-relapse mortality of 32%. The univariate analysis favor TBI on the relapse rate and a longer interval between diagnostic and allo for the non-relapse mortality rate, but no impact of alemtuzumab when given below 60 days. I find this result puzzling because there is clear information provided in the CLL area with this EBMT analysis of more than 600 patients, showing that alemtuzumab within 2 weeks before allo is associated with a much lower event-free survival, higher cumulative incidence of relapse, etc. And there is also no, there was a trend of the use of full conditioning on the relapse rate. And here is this very big CIBMTR analysis, the MAC, the full conditioning give much less survival than the RIC conditioning. So, and finally, I will give you this drug development example of what can be done based on NGS. And here, this is a recent report of Charles Herbeau at the ASH in 2021 in 15 patients treated by ruxolitinib plus venetoclax. They were almost all in relapse, and almost all they were all either alemtuzumab refractory. Sorry, here it's alemtuzumab ineligible patients, and the overall response rate is 73%. And there is in this retrospective analysis, which is not a clear clinical trial, and a potential impact of JAK-STAT pathway mutational status on the progression-free survival curve. So as you can see, there is patients who are still in remission after 1 year. I have one of these patients still in remission after almost 2 years of the combination of ruxolitinib and venetoclax. And this patient had been treated by alemtuzumab. So in conclusion, T-PLL is a clear entity. Diagnostic is based on 4C, clinics, cytology, cytometry, cytogenetics, and it's good to apply consensus and useful to apply consensus criteria published in Blood in 19. There is an aggressive behavior and a poor prognostic, but possible endolymph forms submitted to close watch and follow-up. Molecular landscape has been extensively characterized, and there is tumor vulnerabilities and targetable mutations, with example of JAK-STAT mutations. Treatment options include alemtuzumab plus or minus pentostatin, frontline higher response rate, but with a PFS just above 1 year and OS below 4 years. And you have to use this drug discussion. Allogeneic transplantation remained the only curative option, with an overall survival of 30 to 30%, but a high relapse rate around 40%. And autologous transplantation is just mentioned here, but has been clearly underreported. And I will finish with recommendation. This recommendation has been published by Claire Derden and ASH in 15. So wait and watch in indolent phase, frontline alemtuzumab plus or minus purine analog, consolidation with auto or allo in eligible patients, and in relapse refractory patient, you can repeat alemtuzumab if the patient is 70-52 positive. You can still have 60 to 50% response rate, but a shorter duration of response. You can use bendamustine, and you can try to use experimental agent, and of course consider SCT if not done before. And I propose this optimization of Claire Derden proposal. So in patients with a frontline below 70 years old eligible for allo, you have to consider allo at first response, and then you have to conduct immediately the center who is doing allo. It can be your center, it can be another center, but you have to be quick to contact the center to begin a donor search. At the same time, it's good to send a sample for NGS, can be useful at relapse, and also to try to prepare a way to follow MRD after allo. And at 10 weeks of alemtuzumab, response evaluation, donor check, you have a donor, you're in CR/PR, or in NRPD, depending on possibility, you will add a pentostatin, but in patients with CR/PR, it's this addition of pentostatin is used as a bridge to allo to do the washout of alemtuzumab. But in patients with no response of progressive disease, pentostatin added to alemtuzumab can increase the efficacy of alemtuzumab and can use to obtain a response. And at the time of allo, the choice of TBI is a matter of centers. I am absolutely not sure of the impact of TBI on the results. And I conversely think that MRD and chimerism monitoring is very important post-allo to monitor the CSA, cyclosporine, taperin, and the use of TLI. So I thank you very much for. Oh, sorry, these are take-home message. So first message is T-PLL diagnostic is based on 4C with a demonstration of TCL1 or MTCP1 gene implication. two molecular landscape has been well described beyond TCL1 or MTC1 rearrangement, discovering potential targetable mutations. This landscape includes very frequent ATM mutations and or deletion and frequent mutation on JAK-STAT pathway. 3, aggressive course and poor prognostic. Alemtuzumab remain a standard treatment with a PFS just below, a little bit above 1 year, but allogeneic transplantation, only curative option, should be considered in individual patients. I thank you very much. So I have to, I am ready to answer your question, and I have to have a look at the chat if there is a question in the chat.
So dear audience, we encourage you to start writing all your questions in the chat. We will leave you 5 minutes to write them. Thank you so much. And also thank you so much, Professor Tournilhac, for this amazing presentation. There's a first question, Professor.
Yep.
Yes.
The question is, how does the therapy with CD52 impact the detection of T-PLL MRD by flow cytometry? There is a CR. You can obtain a CR using alemtuzumab in T-PLL. And there is not in CLL, when you obtain a negative MRD assessed by flow cytometry, you had an extended overall survival. There's a demonstration of the impact of the negative MRD. In T-PLL, we suppose that a negative MRD has an impact, but this demonstration has not been made like in CLL, and especially in the context of compound of alemtuzumab. The MRD assessment in T-PLL is important when this MRD is used to monitor a treatment, like when it can be, and then the example is that MRD assessment can help you to manage the immune suppression after allogeneic transplantation. So if you have persistent positive MRD or a raising MRD after allo, that's the time to add something. First, if you have something, maybe to add a JAK inhibitor, maybe to taper the dose of cyclosporine more quickly, for example, if there is no GVH. But usually the duration of alemtuzumab is 12 to 16 weeks, and we stop.
We will wait 3 more minutes, so please write all your questions in the chat. Thank you. So I think there is no more questions from the audience, so we're going to finalize this amazing presentation. So Professor Tournilhac, thank you so much for this interesting presentation and discussion. And before the closing, I would like to remind to the audience to answer the survey that will be sent to you after in few minutes. And moreover, do not forget to follow us on social media channels to be updated on the last EuroBloodNet advances. So thank you so much, everybody. Good afternoon.
Thank you.
Thank you so much.